I would just say from a personal point of view, when we were doing the discussion, the chair and Michael Overmans and Thierry Andre were seeing a stream of chat questions, and there were just too many that we could answer in the time. But let's address the top two, and I would like to, that were discussed, and I'll summarize that for our audience now, and a few others which I think are really important. So the top two voted questions was, what is the role of potentially giving combination chemotherapy of immunotherapy, given the fact that almost 30% of the patients in the Pembro arm progressed versus only maybe about 12%. Now, we haven't got on top of that question really completely. If you go based on the evidence of a phase 3 trial, the way we designed it, and in terms of the patient quality of life, I would definitely say still to give patients the chance of having essentially chemo-free treatment and maybe a chemo-free life, first-line Pembrolizumab is the new standard of care. Having said that, we don't have the special biomarker yet to say why we might want to give only monotherapy PD-1, such as Pembrolizumab, versus chemotherapy plus immunotherapy, like we do in some of our lung trials and upper GI studies. And those, we discussed that in the discussion section, that some of the upcoming studies, such as the COMET trial, which is atezolizumab versus FOLFOX, bevacizumab, will come through and give us some of the answers, okay? But that commits you to a definite FOLFOX arm, so may not be the best thing for our patients. The other question is, would we give combination PD-1 and CTL4 based on the non-randomized data from the CheckMate study of Nivo-Ipi? Possible. I mean, all of those are possible, okay? But if you again go back onto the basis, this is the first randomized phase 3 trial of immunotherapy versus chemotherapy, you would go with, at the moment, saying that combination is really in the context of a clinical trial, in my opinion. Now, I think that led on to the question of, well, are there other reasons why you may have got this more rapid progression-free survival efficacy lack in Pembrolizumab? And it came to the question of pseudoprogression. Now, in this trial, it was blinded central radiology review. And so myself and Thierry Andre, the first author from the ASCO presentation, both argued that actually we do think that pseudoprogression will play a significant part in doing the kind of misread of progression. So pseudoprogression is that you think the tumors are getting bigger on immunotherapy and then they shrink because maybe of the inflammatory response. And I have certainly seen that on some of the patients on the trial and also off trial. And we have done what we call CEA trajectories. So the patients would have had CEA blood tests, and we can see some patients where the CEA dramatically goes down, they feel better, but the tumors get worse. And it was actually quite a battle to try and convince the central sponsors that they hadn't progressed. So I think we think that that is a significant issue around pseudoprogression. That may also answer the question around the PFS2 endpoint being actually still pretty good. So that means the patients who we think actually progressed on Pembrolizumab probably didn't really biologically progress. They were probably responding with pseudoprogression. And then, yes, they cross over to chemotherapy, but they were still having a benefit from first line. Now, that is completely my own personal view at the moment in terms of where we think it's going. And what our aim is as co-authors is that when we are getting the next data lock, which hopefully will be in the next few months and we can report over survival, we will get more data around that, okay? And so that we can answer that question better, which is it's in our gift and it's our requirement to do this for our patients and our peers and our scientific community. Now, just a couple of the things that I wanted to mention that we just didn't have time to talk about was someone asked a very good question about what about the subgroups of KRAS mutant, NRAS mutant, maybe with Lynch. Now, I think, again, we've got to realize that in this trial, the only real mandatory biomarker in terms of the biology was that they were MMR deficient or MSI high, okay? You didn't have to state whether you knew the KRAS, NRAS, BRAF data, because to be honest, you don't need to know that at the moment. There was no other, all the previous trials had shown that the only biomarker to say that you would respond or not to immunotherapy was MSI and MMR. And then even in terms of Lynch, not many patients know they have Lynch before they go into stage. Some do, and they've been living with Lynch syndrome for a long time. But I had a number of my patients who were young and for the first time were told you might have Lynch syndrome, and it took a while for them to know. So again, at the beginning of the trial, it wasn't mandatory to know these things. Now, of course, when we now look at the subgroup analyses, everyone's looking at, oh, maybe KRAS mutant, not very good. What's happened to Lynch patients? Well, I think there's two things to say that. Although they were what I call pre-specified subgroups, for the statistical analysis, they weren't powered in that way. Okay, so we couldn't power this study on something that we didn't know, because none of the prior studies had told us that maybe KRAS or NRAS mutants were going to do less well. And if you actually look at the analysis, the lines cross one, and similarly for the Lynch patients. And so, I mean, that moves into, you know, what does that mean in terms of PFS2? And a lot of patients, another question was, what happened to the subgroups of the subgroups in PFS2? Now, again, really important question. And, you know, we as co-authors really know this is an important question, but we probably can't answer that quite yet, because PFS2 was an exploratory endpoint. Okay. And if you think about it in terms of knowing what happened to the patients off trial, the only things we are allowed to really ask is, were they on? Okay, what do they have? Surgery, what chemotherapy, what systemic therapy, and have they progressed? So we couldn't really ask them what was the depth of response, what was these things, because the only group that we could really control was the group who were on chemotherapy within the trial, and within the trial crossed over to Pembrolizumab. So we will report those data, but it won't be very clean data. Okay, so I think that that's not really an answer yet, but we hope we will get those answers in due course.